but no, that's great. I'm really glad to have everyone on today. I'm a little bit less formal than a lot. So if you have a question, I have no problem. And I actually would enjoy interactions with people, questions, asking me, having me say something clearer, because at times we can be off a little bit. But I'm going to go through and I'm going to probably, the biggest thing and the hardest thing I think when you're looking at education is kind of really simple. It's all black and white. Well, everyone thinks it's black and white, but it's never black and white. And what I'm talking about is, when do you know to do something? When do you know not to do something? I've been fortunate to have numerous fellows over the years, and it's interesting. Neurosurgery residents are so concerned with the technical aspect of problems that a lot of times they forget what's really important is to know who to operate on. Because you can do the technical greatest operation on someone, but if the surgery is not indicated, you're probably not going to get a great outcome. And I love my colleagues in neurosurgery, but I think the most important area where indications and who to do something to and who not to do something to is in the spine. And so I think we as physicians and surgeons need to understand this better and hopefully make better choices for our patients in the future. And so with that said, I'm just going to quickly go through, this is actually my dissertation for my master's and some of the work I did for it. Okay. So essentially what we're going to do is I'm going to break this down into several parts. And this is just a simple overview. We're going to start and we're going to go and look at the U.S. healthcare predicament. And really, you probably heard this a lot, but really the question is not how much things cost, because I'm not a huge person about how much things financially cost. It's more important to the question, is it worth it for the patient? Is society going to gain something by doing that procedure? The second thing we're going to talk about, lumbar spine fusions. And just since we have a new audience, I just want to make some quick definitions for you. So you're going to hear me say evidence-based medicine concordant and evidence-based medicine discordant. And what that means is that we looked at the guidelines, and if something was concordant, it fell in what the guidelines recommended. So if you did a surgery and you followed the guidelines, that was called concordant. If we thought you did a surgery and it fell outside the lines of the guidelines, then we called that discordant. Now, I just want to really clarify, if you do something outside guidelines, that doesn't mean it's wrong. It means, every patient's an individual, and guidelines are sort of like guardrails on the highway. They're just there to help you stay within the lanes, but sometimes you need to get off the highway. And so it's all right to step outside guidelines. MCID may be familiar to some of you people. It's called the minimally clinical important difference. And a lot of different patient-reported outcome measures, also known as PROMs, is you try to define an objective number where the patient states, this operation was, I would consider it a success if I gained X number of points. And so we'll touch base with that a little bit. The ODI, probably something you heard before, was Os-Wesley Disability Index. And last is substantial clinical benefit. And as opposed to the minimal benefit patients get, this is patients said, wow, you hit it out of the ballpark if you get X number of points. And I'll step back and talk about that. Next, I'm going to just go over really quickly what our study design was. We'll look at our results, and then we'll have a quick discussion about stakeholders and education and what the future holds. So how did we get here, and why did we get here? I'm a little older than most of you, I would guess. But back in 2017, the American Board of Neurologic Surgery made a change, and they redid their boards. Classically, supposedly, the accept rate was about 80% of patients passed their boards. In 2017, they made a new section, and it was based on patients' cases. And what happened was there was a high number of failures that year. And why? It's because younger surgeons, as I will tell most like older surgeons, actually failed based on the indications for their surgeries. So that got me thinking, and really got me into the thought of what is the indication of a lumbar spine surgery. and I'll go through some of the things I did. The second problem that we have in the US, and this is something I'm sure everyone's heard about before, but about 20% of our gross national product is spent on healthcare. And to me, I'm like, well, 20%, if you're trying to make yourself healthier and better, that could be not a bad problem if you're looking at quality of life. The problem is that in other comparable countries, we're about 5 to 10% higher, which is staggering. That means we could have 5 to 10% extra dollars to use on other things in our society. So it comes down to when you look at what you're getting, instead of looking how much cost, a better way to look at it is value. So value equals quality divided by cost. So if you get a lot of quality for something, that's great, but then you have to look at how much it costs. If you get the same amount of quality and something is 2 times more expensive, that means you're not getting very good value. And you could get two of the same things for something that is less expensive. So let's look at some of the big life expectancy. Life expectancy is one of the biggest measures for quality in a community. How's the community doing, and how is their quality of care? So if you look at the US, we spend about $8,000 per person for their health expenditures. And this is somewhat of an older slide, but even the more recent stuff show that. However, if you go back to the other areas of the world, you'll look that they spend 4 times less for less and get the same life expectancy. So what does that say? Yeah, we're doing all right, but value is we're 4 times more expensive. And so, so our value is 4 times more expensive. So we need to look at how can we do things better. So I'll go really quickly into this. Healthcare is based into failures in different areas. We're really going to talk about overusers in around care. So let me just step back a little and remind everyone about spine conditions. If we look over to the far left side of your screen, that's normal lumbar anatomy. You have a bony tube around your spinal stenosis. When we talk about a decompression, we talk about taking the bones off and opening up the nerves. And a fusion is actually where we put bone on the sides and have the two different spinal segments healed together. Now, it's important to understand for you all that the screws we put into patients are actually only an internal brace. The fusion is the bones healing on the side. So I'm going to go through some, the 4 major stakeholders when you're talking about lumbar fusions and spine surgery. So for the surgeon, it's kind of easy. We are biased and we make our living on operating on patients. So what does that mean? And in the US, there's something called an RVU, or resident, I can't even remember it, research value unit. And what happens is revenue value unit. Every time you do an operation, you get paid based on that. So what happens is you get somewhat of a positive feedback loop. The more RVUs you drive, the more money you make, and the more successful you are in terms of financial. So what happens if you do a decompression or a fusion? And I very much summarize this, but in general, is if you do a decompression, you only get X RVUs. And if you do a fusion, you get 3 times more RVUs. Now, why is that? Because a fusion tends to be a much more complicated operation, take longer. And if you look at it from a completely financial reward issue, is surgeon does more RVUs, they tend to get paid more. So what about the patient? The patient really doesn't care what you do to them. They just wanted a good outcome. And that's their whole driver. The problem is if they have a bad outcome, unfortunately, they go back and they have another operation typically. So again, you have another feedback loop that's going back and talking more about operations. The hospital, similarly, is very well reimbursed for fusions versus decompressions only. And lastly, you have the payer. The payer doesn't want you to do anything, so they're very easy. They want you to have nothing done and get a low-cost option. So as you look at this all, you're going to see that the payments tend to be much better for operative things. So the question you have to ask yourself is, well, if you're getting value, are we really getting our value with our lumbar fusions? And if you look at the numbers, the number of lumbar fusions has drastically increased over the years. And so we're now doing multiple times more fusions. And are we really getting a lot better outcomes? This is an interesting slide. It was done by Dan Weinstein many years ago. And it's interesting, if we're all doing the same thing and we're getting all the same value, you should get the exact same color map across the country. But what we see from this map is there's regions where there's 5 times, even 10 times more number of surgeries than other areas. And this is actually one of my most favorite figures that I've seen, and really tells to me is shows you how heterogeneous the area with lumbar fusions there is. So this looked at every one of the Medicare distributions. They looked at how many times they paid out for for example, for a hip fracture. And hip fractures are kind of interesting. There's pretty good data, and most people treat hip fractures the same. So if you look at that, they're very close to the line at 1. Now, this is a logarithmic scale. So when you look at the hip replacement and lumbar discectomy, they get higher. But the most incredible thing is if you look at this individual over here, this hospital does 10 to the 7th times more lumbar fusions than the mean. So that's 70 million times more lumbar fusions than the mean hospital. So I'm pretty sure that when we're talking about value and revenue and homogeneous patient care, there's some reason why this is such a spike. And that's what we got to get away from. And that's why I propose that when you look at things, you probably should find the evidence-based data and see where it goes. And just to be fair, this is Jefferson's volume, and we absolutely have an upward trend with our lumbar fusions. So I don't want people to think I'm casting stones on anyone. I'm really trying to look back on all of us and see how we do and can we do better. So I'm going to give you a couple of different things, and I don't know if anyone's on or anyone's wants to shout out an answer. I'll just go through. So what we did, the first thing I did is I actually sent questionnaires out with everyone. And I said, okay, here you have a 74-year-old patient. He's got low back pain, severe low back pain. He's undergone non-operative treatments. And how many people would operate on him? Majority would operate on him. Again, not everyone. And the next question is, well, would you fuse him? And this is where it became very interesting. This patient does not have any deformity, does not have the lumbar stenosis, but almost half of the people I questioned said they'd go on to fuse him. I then went down and I looked at a lot of different treatments, and I'm going to sort of skip through this for everyone. But in summary, it was all over the place. There was only 20% agreement. Only 20% of the cases had agreement and should a fusion be done. That was 6 out of 30. So then it goes back to what is an indication, and it's really hard to define what that is. And I know that sounds, to non-surgical people out there, I'm sure that sounds astounding. Like you should know when to operate and you shouldn't. And unfortunately, we don't do very well with that. So I'm just going to keep on going through this. So the problem is the U.S. Healthcare system is volume driven and it's not quality bind. We only have a finite number of resources. And as I just showed you, the care is all over the place on how you treat people. Now, lumbar fusions is one microcosm of indicative to all of healthcare. There's no definition of indications. And interesting, I tried to go out and find evidence-based guidelines for lumbar fusion, and I couldn't really find them. And I'll go through that because you could find specific points, but you couldn't find a overriding fusion guideline. So we made this basically algorithm. What we did is we set up 2 different pathways. One was for education, and the other one was to try to get better outcomes for my department and to find what indications are. And I'm going to go through that. And I'm going to go through this really, really quickly because if you're familiar with the quality-based quality improvement measures and algorithms, I'm going to show you a couple of tools that are great to help. And one of the things is they call a threat and opportunity matrix. It's very simple. You look at what are the opportunities if I do this versus if I don't do that, short-term, long-term. And it helps understand why you're doing this and who is it going to benefit. And so the second thing is, and so you can do that, and you should do it pretty much for all your projects because it helps you when you have to present these out to patients, to a committee. The second thing that's kind of another great thing to do is called the stakeholder analysis. And why it's important is it really starts putting out in your mind, okay, who's going to be influenced by this, number one. And number two, are they going to be helpful and how helpful? And the second thing you want to understand is, are these people going to be against my project? Because those are the patients you need to convince the most to get onto your team and get along with the project. And so you need to devote some considerable effort to pushing your project along. And again, other people that we have, and for us, the nurses were unbelievably supportive for this. IT team really had no interest in helping us, but would do it since we got our bosses and our sponsors. So we built and if you're looking for a book, another really good a book that really talks about building things and moving forward is Cotter's Creating a Guiding Coalition. And it really talks about how you get people motivated and how you push forward. So what I did is I built a grading sheet for every patient. And then I used the NAS appropriate coverage position, which is the best evidence-based policy you have when you're looking at lumbar fusions. We went through, and then there was 9 different areas where we talked that patients had indications for a fusion. Now it's kind of interesting because when you look at some of the data for it, some of it wasn't great, but it was the best data available. And again, that's what guidelines are. They're trying to give you the best data, best evidence to make some decisions. So went through it, and then I had to say, okay, how am I going to measure this? And this is a validated study. It's called the Oswestry Disability Index. Very simple tool. It's actually great if you've never heard of it. It's 10 questions. It takes the patients about 3 minutes to fill out. And essentially, it rates everyone between 0 and 5 for the 10 questions. And so you get a score. You want to have a score of 0 because what it represents is what percent disabled you are. So you get the 50 points, you multiply it by 2, and that's your percent disability. So if your score is 20, that means you're 40% disabled. And this has been validated in multiple different ways. And so when you look at the ODI for our patients, typically you're talking in the area of about 20 to 35 in general. In order to get them better, remember we talked about the MCID is the minimally clinical important difference to improve patients. You need to drop them by 5 points. And if you want to make them, if you really are doing great, you want to improve them by 10 points. And so these are the things when we set up, we said, okay, how do we do and what do we do? So then we made an algorithm. I'm going to skip through this really quickly. Is basically you went through, we measured their scores, we followed them. The one thing I did do is preoperatively before any surgeries, and I actually still do this today because I thought it was such a great tool with the residents and medical students, is every Monday I sit down with every case for a lumbar fusion at Jefferson for the ensuing week. And we go through with the residents and we say, okay, does this meet the evidence-based guidelines? Does this not meet the evidence-based guideline? And we discuss it, and hopefully, hopefully we're not having many that don't. But again, guidelines are guidelines, and they're only there to help you. And so we went through, and then we followed their outcomes up for 12 months. And what we found is, here's a patient that 60, I'm going to give you a couple of really quick examples. 69-year-old lady came in with bilateral leg pain. She had a grade 2 degenerative spondylolisthesis with severe stenosis, underwent a L4-5 transfemoral body fusion. And we didn't really concentrate, and we didn't really focus on what operation they got, should they have gotten an interbody fusion or anything of that sort. And we're going to go back, and I'm going to talk about that in 1 second. But we looked at this case. So as you look, it's one of the 9 indications is for deformity in terms of degenerative spondylolisthesis is an indication to operation. So it's an evidence-based medicine concordant operation or an indicated fusion. And this patient did quite well. Her ODI went from 16 to 2 at 6 months. Next patient, and here's a patient that didn't do as well. A 57-year-old man with neurogenic claudication. He had exhausted all his operative treatments, underwent a 5-level lumbar fusion, really did not have a deformity, did have a lot of stenosis, but unfortunately this patient did not meet the guidelines and actually did not do very well and actually got 2 points worse at 6 months with his ODI. So then, we went and we looked at historic outcomes, and I'll skip through this really quickly. But what we did by setting up this algorithm, our ability to collect outcomes on our patients, we went up from 28% before we started the project to 100% collection of ODIs for all these patients. After 6 months, we actually had about 325 patients in our database with 6 months follow-up. 5% were lost to follow-up, which is actually pretty good when you're doing these patients. So what happened and what were the results? So if you looked at, we looked at these people at 6 months, and this is, you got to take into a grain of salt that some of the patients, have other issues. It's an elderly population. So if your patient does fantastic and then has a bad hip and they get weakness and disability because their hips are bothering them at 6 months' time, it doesn't matter. Your ODO guy goes down. And so your surgery might have been great. We are following just a general outcome metric. So that's one criticism. But with that said, is if you look at the whole group, almost 80% of patients improved. 12 patients, about 4 or 5 patients, about 4 to 5% with no change, and 16% did decline. And so when you looked at the patients, you'd say, oh, that's not that great about decline, and we'll go through that in 1 second. But as you went through this, almost half of the patients actually got better and had a substantial improvement, what we talked about, as opposed to the patients that declined. Most of them declined, pretty much stayed around where they were before rather than drastically declined. So then we went through and we said, okay, now let's figure out what's going on, what happened, and how to hang. We looked at the indications. Remember, I said there was 9 different reasons for it. So if you look here, we broke them down a little bit more from the 9 major reasons. But these were the different indications. And then we looked at of all the indications versus the patients being evidence-based concordant or evidence-based discordant. Only 7% of the patients were defined as evidence-based discordant. So here's the summary slide. This is called the violin algorithm, if you've ever seen it. We then went through and we looked at, of those 9 different types versus patients that had what we call NAS discordant or evidence-based discordant. And we see there's a statistical difference in that if you were concordant or followed the guidelines, you did significantly better than the evidence-based medicine discordant. So the story is at least if you follow the guidelines, you tended to do much better than not following the guidelines. So then we broke it down even further and we said, okay, well, let's look at all these other areas. And as it turns out, there were a couple areas where there were things. Revision patients did fairly well. And then we did further statistics and we looked at, I'm not there yet, but the ODI improvement, I'm going to step back for 1 second. At 6 months, the single biggest improvement was if you had concordant versus discordant. So if you followed the evidence-based guidelines, you tended to get almost 5 to 6 points of improvement. And we talked about before, that's a significant improvement and passes the mean clinical important difference. So just I'm going to step back for 1 second. We also looked at, the question is, am I a better, surgeons are always asking this question, am I a better surgeon than that surgeon? Can I pick my patients better? And if you ask every surgeon, the answer is yes, I'm the best. But as it turned out, when we reviewed our 5 different surgeons, they all had very similar improvements, and it was not a statistical improvement where one surgeon was better than the other surgeons. Revision surgeons, I'm going to skip that. Last thing is, what about the residents? The residents, the big reason to do this is what I was really trying to see is if I could help the residents understand what an indication was for a lumbar surgery. And this is what we showed before, the number of mistakes on the patients. I guess I could have been more positive and done the number of correct answers. But we looked at the number of mistakes the residents did on their surveys where we had 30 different questions and algorithms and had them decide what was indicated and not. And we had a great improvement in the residents. As you look at it, it was kind of interesting. The people that did the best were the 3rd-year residents or the PGY4s. And I think that's because I started this 3 years earlier. So those ones had 3 years of data. And the second thing is, and I don't think the PGY5s and 6 had as much interest in it because they had, some of them have gone into other areas of neurosurgery. And number 2 is, I think once you start understanding and learning things, it's harder to get retrain yourself. So in summary and in conclusion, what we found is we were able to collect outcomes on all these patients. The evidence-based guidelines was the single biggest statistical area which judged patients' improvement. So that means that if you looked at the surgeon who did your surgery, the type of surgery you got for the operation, how old you are, and a bunch of different areas, that did not matter. The only thing that mattered, or the thing that had the highest odds ratio to success, was having evidence-based medicine concordant surgery, or in other words, following the guidelines. So with that, I would say, I really think guidelines are important. As younger people coming out and trying to work the world, I think one is we need to make better guidelines, and two is your decisions probably should be viewed on by evidence-based medicine. And I thank you.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.